that in the chat box. So I'm going to talk about the suction scoop and suction sheath, which seems to have a lot of buzz recently, especially given that suction seems to be the way forward, especially when it comes to residual stone management and so on. So these are my relevant conflicts for the talk. I think the future would probably involve suction in some way or the other, whether you're going to have a scope or a sheath. So here we've got the piece and suction scope, the 7.5 and the Seplu 1012 axis sheath with suction. I just want to point out here that if you're using the 7.5 scope, the differential of 3 French is probably very useful. If you use a much bigger axis sheath with suction, then it sometimes collapses. So 3 French is probably ideal. So that's why if I use a 7.5, I use a 10, 12, and maximum 11, 13. I won't go beyond that. 10, 12 works very well, and it's still quite small and agile. So let's look at the innovation, development, and clinical adoption of ureteroscopy as a time trend. So right from 1954, there has been lots of innovations, and you can see different time trends, different time points through the decades, through the years. The last innovation actually is the suction scope. That was the Pearson 7.5. So actually, if we talk about the long list of innovations of flexible ureteroscopy, the suction is the last innovation that has been added to it. And hopefully, the future will be with different sized suction ports or having wider channels for suction. In terms of ergonomics, Ananda has showed the suction cystoscope. This is no different. You've got the handle, you've got the TUI port, which is attached, the fluid connector. So it is very similar, except in terms of the design to the suction cystoscope. Now here you've got the port there, which is for the fluid management. You've got the TUI port for the laser. You've got the suction button, very similar to the cystoscope, and the deflection at the back. So these are similar to what you're used to. And the suction is connected to the spout there, which you can see, and you can move it on either side. So it doesn't matter which side your suction is set up, you can move it to either side, and it's controlled by a finger button. I find that very, very useful because then you are in charge and you can suck as much or as little as you want. So the main advantage, apart from what Joe has said about single-use scopes, is actually the integrated suction system that helps you to manage and maneuver a little bit better when you're operating, and I'll show some videos of that. So here I am. How does it work? So the same channel, where the fluid is connected on the other side and the suction is connected, and you can see it's intuitive. And actually, sometimes when you're sucking, you have to be careful because you do need more irrigation, because otherwise the irrigation runs out. But you just can collect. Now, just to also be very clear, it is not to suck fragments. If you want to suck fragments, you'll be disappointed. But it does suck the fine debris, etc. So here we are, a 48-year-old female with 2.1 centimeter renal stone, the histories of recurrent UTIs, and we wanted to use the suction scope for 2 reasons. One is to suck out the debris, and second, to minimize the operative time with low intrarenal pressure. So to get the best of this. So I'm just going to let the video play by itself. So in the end, we needed about just over half an hour, 32 minutes for this case. You can see when I'm fragmenting it, it is the fine dust and fluff that I'm sucking. It is not to suck the fragments, but what it does is, because it's sucking the debris, you are able to operate for longer without having to start, because otherwise the vision gets obscured. You're less worried about intrarenal temperature, pressure, because you are sucking intermittently. So as you're doing that, the pressure and temperature is less of a concern. If you were to continuously fragment, then it will be more of a concern. So again, you continue with the intermittent aspiration, intermittent suction as the fluid goes, and it really speeds up the process because you can laser for a lot longer. Once you have lasered completely, then you can, I generally go with pop dusting after that. So here you will see I've started pop dusting the stone, which means the stones are coming towards me. And the setting for that I use is about 0.6 to 0.8, 20 to 30, sometimes up to 40 hertz. And the stones are coming towards you. So once you start doing, in the end, you're left with fine dust and debris. Now, the debris and the fine dust will get sucked, but not the fragments. So Once I've completed, as I'm coming out, you will see that actually the fine dust is getting sucked out. And I think that's the point, that you're not going to be able to suck the fragments out. But again, because you can go on for a lot longer, you're not that worried about lots of different things. The vision, as you can see, is very good. This is towards the end. It is just dust. And as I'm coming out, I'll use the suction again, which you are controlling, and you will see the fine dust and debris getting sucked out. So for me, we use it routinely now for a lot of our cases, not for every case. And here you can see I'm using the suction, and you'll see the stuff getting sucked out into the channel, uh, which is quite good in a way. And you can have sometimes enough for stool analysis if you go on for a while, but it needs to be fine. This is a second case. This patient is young, referred from elsewhere with iatrogenic mid-ureteric stenosis and a low pulse stone, symptomatic. And again, the idea here was to overcome the structure, which was quite a tight structure, and optimize the operative time. So I'll show 3 short videos in this. The first one is to do an endopilotomy with the 7.5 scope. I'm not using suction for this bit, but the smaller scope definitely helped. So here I am trying to do a limited endopilotomy, 1 joule, 5 to 10 hertz, to open it enough so I can get the scope in. Once the scope goes in, then you start to, so this is the second video. As the scope goes in, you can see there's a lot of dust and debris because it's a very dilated system. So rather than having to syringe it out, bit by bit by bit, which takes a little bit longer, more effort, you can use a suction to just continuously suck and get the stone closer to you. So that's another advantage. When you use suction, the stone, you can kind of manipulate the stone to come closer to the end of your scope. And then once you've done that, that's a stone in view. Again, I'll use intermittent suction to keep getting the stone closer to me because the system is dilated. So you can use the suction to manipulate the suction a little bit to your advantage. So as I'm doing it, I intermittently suck so the stones keep coming close to me. So especially in a dilated system, this can be quite useful. Here I am trying to move the fragment just by using the suction button. So it's not enough, but sometimes you can see that you can just manipulate the stone fragment just by using the suction button. So it's powerful enough to do that, but probably not enough to remove it completely outside. So what was my first impression? I think it was flexible, maneuverable, good vision, and suction allowed the clearance of debris and possibly reducing the operative time. So this is the first study, multicentric, from 6 centers, 5 European and 1 Asian center, that was recently published in World Journal of Urology. Prospective consecutive patients with 57 renal stones. The stone volume is reasonable. Cumulative stones diameter was about 18 millimeter plus. A lot of them had multiple stones. An integrated suction, when we asked the clinicians, was helpful in about 95% of cases. And as I said, you don't have to use in every case. Having that gives you the extra maneuverability or extra choice of using it if needed. Intraoperatively, 50 minutes mean operative time. Lasing time was just about under 20 minutes. Access sheath was used for majority. Remember, these are big stones, so I do tend to use access sheaths where I can. Suction was helpful in majority. When we look at post-op results, the stents were there in about 84%. There was one minor bleeding. There was no other post-op complications. Stone-free rate was good, 84%. And for stone sizes bigger than 2 centimeters, again, it was quite good. The follow-up was done at up to 6 weeks' time. So we then asked the clinicians about different aspects. So about quality of scope, and if one was, not good, etc. So most of them scored very good, or between 4 and 5, similar with the pre-existing scope placement, visual quality, and so on. Most scored between 4 and 5. There were not really that much laser interference, and most people, if cost wasn't an issue, would prefer to use a suction disposable scope. So I think this clearly gives an indication that the scopes offer something which is of a good quality. Suction helps, maybe not in all cases, but in future, probably larger operative channel where you can actually suck fragments out. I know Pearson is coming up with one. I think it's now going to be marketed in the UK shortly, and we are hoping to try to see whether the suction can actually suck fragments out and to what extent and to what level would the fragments get sucked out. Is it 1 millimeter to, I think up to 1 millimeter, 1.5 millimeter probably would be able to, but time will tell. So we are waiting for that. So that is probably the feature of suction scope. What about suction sheath? So here you can see a suction sheath in action. You can see the degree of bend. It actually bends quite a bit. So again, the advantage is once the suction sheath is in place, because the tip is obviously flexible, bendable, navigable, and you use the scope itself to navigate through it. So here we are using a suction sheath. It's a hard stone. The idea is to break the stone, and normally you would leave it and assume that it's small dust, it'll probably pass. But here with the suction sheath, you could bend it enough. In the lower pole, it was a 2 centimeter stone, and you would see once I have fragmented everything, I will then use a suction sheath to actually bring out the fragments actively into the end of the suction sheath. So you're actively sucking out the fragments. And I think that is a real advantage at the end, because these patients would probably go on to get residual fragments or regrowth. So you can see that I'm coming out with the scope, and as the scope comes out, the fragments get sucked out in the side channel. Then you go back in, again, wherever you want to go, you go back in and do the same process again. And a few fragments at a time, you keep doing it. It does take a little bit of learning curve. It does take a little bit of getting used to. It may not exactly work how you anticipate in every case, but in most cases it works well. And you can see again, I'm coming out. So I use a Seplu sheath nowadays. It's probably most cost effective, but there are different different sheets in the market. You can use any of them. And essentially the idea is to get to the scope, to the stone, and you can see, you can really navigate with the scope in place, get to wherever you want, and the fragments come out. In the olden days, you would end up basketing it. It takes longer, you get tired. It's very hard to basket the dust, the fine dust. Here, fine dust, fragments up to 2-3 millimeter, you can just get it out of the sheath with no problems. And I think that is a real advantage of using these suction sheets. And this is why I think it's a game changer, because one of the main aspects which we are not good at is prevention of residual fragments, because we know that residual fragments will grow in time. So this is a pediatric case which we had planned for a PCNL, but unfortunately the stent had retracted up. So we were going to, I think I'm going to play this video. So we were going to pull the stent down. We had to, and in the end we decided, okay, since we went up, there was not that much actually in the kidney. So essentially what we were going to do as a PCNL, we decided that we'll take the stent out, position it, and then we will probably go for a suction sheath and try and do it retrogradely. So what was a planned PCNL, here you can see the stone in the kidney. This is a pediatric patient, planned for PCNL, but in the end, we didn't do a PCNL. We used a suction sheath. We managed to break the stone and we sucked out all the fragments. So this probably will push the limits of what we can do. I'm not saying you should do it for all stones. Certainly not. I think you'd still need to do a PCNL for staghorn or partial staghorn stones. But all I'm saying is there are certain cases where having a suction sheath will allow you to push the limit to do these stones retrogradely, which otherwise would have needed a PCNL. So here you can see lots of dust and debris. I keep breaking. Luckily, the stone is soft. Once we break it, you'll see the suction sheath in action again. And all these fragments, all this dust, debris, mucus type material, you'll see it's getting sucked out bit by bit. And once you start doing that, how much can you do? How much do you have to suck? How much suction power is needed? Some of the answers we don't know. Only time will tell. And as I said, it doesn't always work as well and as efficiently in every case, but where it works, it is a treat. So in this case, it really worked very well for us. So here, after you fragmented everything, and I usually try and fragment before I use the suction sheath, because if you try and do it intermittently, you then have to go back, fragment a bit, suck a bit. I don't like to do that. So I fragment everything I can, and now you can see all the fragments with suction is coming out. And in there, we went in, it was completely clear for what would have otherwise been PCNL. So you keep going in and out, and you keep sucking out fragments, bits from time to time, till you completely clear it. And as you navigate the sheath into wherever the dust is, sometimes this dust will, you can see the dust will just follow even when the scope is not going in and out. You will still be able to get the dust out. And I think this is a really good way of getting out big fragments. The question that some people ask, do you have to use a basket? I tend to for most of the cases, because sometimes you can see here, there's a little bit stuck there. Sometimes there's a bit of clot and the fragments are stuck on the clot. I like to remove everything. So I use it. You don't have to use it on all cases. In some cases, you might be able to just keep sucking out this way. Here you can see this is one of the last bits, almost like a mucus material. I'm sucking out and then it's completely clear. So I think this offers a very good way of clearing out stones, big stones. And there we are. This is the end view. Just a little bit of dust, which is a dilated kidney, plan for PCNL in there, and we did ureteroscopy. So there are different ways of applying suction for retrograde intracranial surgery. You can do it via an access sheath, via the scope, via a special catheter. And I think intelligent pressure systems are going to come, which might even help us in the future to do a better job. Going on to the suction sheath and what is the evidence for that? So you've seen the evidence for suction scope, which was published recently. This is the largest paper on suction sheath, where patients, almost 400 patients with stone volume of 1260 millimeter cube, had a CT before and then 30 days, within 30 days of surgery. So these are all patients who had a CT after surgery, and the stone diameter varied, but most were between sort of 1 and 2 centimeter, but about 17% were also larger than 2 centimeter. When we look at it, TFL was used in about 46%. Lasing time was short, 18 minutes. Overall operative time was 49 minutes. One patient had blood transfusion, low-grade fever in about 3.3%, but 0 cases of sepsis. There was a low-grade ureteral injury in about 2%. And I have to say that sometimes there's a little bit of learning curve in navigating it inside the system. Now, if we take the stone-free rate as 0 fragments, on the CT scan, it was 58% was stone-free. But if we take up to 2 millimeter fragment, which is commonly accepted in urology, in endourology, it is 97%. So 97% patients on the CT scan, if we consider 2 millimeter as a cutoff, which is often considered, were stone-free. So this goes to show that actually the fans or the flexible navigable access sheath has got a very, very bright perspective. There were no cases of sepsis and very, very good stone-free rate. So is suction the future of endourology? I think there are several advantages of suction. The pressure control is a little bit better, or you're less worried, I would say, because you are intermittently sucking. Similarly with temperature, if you're lasering, you are worried about temperature. Here, you're sucking intermittently, you're less worried. Visualization is good. Probably you'll push the procedural limits because it does increase the speed of procedure and hence reduces the risk of complications like sepsis, which I've already shown you. Stone-free rate definitely is improved. There's no question of that. I've shown you the video, I've shown you the evidence. Definite improvement in stone-free rate, especially with suction sheath. So what are the disadvantages? There is a little bit of operational complexity. You have irrigation system, but you also have suction. I normally use a suction scope, and if I'm using a suction sheath as well, I just disconnect the suction scope. So during the procedure, I'm using suction scope, disconnect the suction, put it on the sheath at the end to remove the fragments. You do need a little bit more fluid than what you would normally use. The suction parameters, we still have to define it. We still don't understand it as well. There is more irrigation. So this is the most recent evidence of suction using ureteroscopy. This is a systematic review meta-analysis published just last week. 16 studies were included, analyzing almost, over 1,000 patients in the suction and standard groups each. And the application of suction improves stone-free rate, reduce infectious complications, and length of stay. So now you've got the evidence to show that suction improves stone-free rate, improves the overall and infectious complication rates, and reduce hospital stay. So I think, given that suction scope, suction sheet, you've got different ways of applying, but definite improvement in parameters and definitely here to stay. So what do we want the future to look like? We need smaller scopes. Of course, we need scopes that are least invasive. We want to dust it. We want to suck them out to clear it. Better monitoring of temperature and pressure. Maybe use artificial intelligence to predict outcomes so you can counsel the patient better and no recurrence. That is how I see the future.